topic. Today I'm planning to discuss the basics of fluid therapy. Earlier we used to say fluid management, etc. Now fluids are also considered as a part of treatment. So we should have an idea of what we are talking about. And at any point of time, if you think I'm going a little fast, you can stop me so that we can clear it then and there. So what will be the layout of my presentation? I will discuss the distribution of body water with composition of body fluids. Why nephrologists are interested? Because kidney is the major player. And the fluid correction involves 4 R's. That is, R first is resuscitation, which aims at the correction of intravascular volume. Then every person requires a routine maintenance fluid. That is a basic requirement of water and electrolytes. Then if you are losing, as is through vomiting or diarrhea, fluid is lost or postoperative loss, that has to be replaced. And in patients who have ascites, etc., you have to redistribute the fluid. So the fluid correction has got 4 R: resuscitation, routine maintenance, replacement, and redistribution. Lot of mathematics involved in fluid therapy. So we have to calculate how much of the deficit before we decide on how much of fluid is to be given. We will have a brief note on the parenteral fluids which are commonly being used and how it gets distributed in the body compartment. So this is how the body water is distributed. This is called as a 60-40-20 rule. That is, if a person is weighing 70 kg, 60% of the body weight is water, of which 40% is the intracellular compartment and 20% is in the extracellular compartment. So in a 70 kg adult, the intracellular fluid will be 70 into 40, that is 28 liters. And the extracellular fluid will be 70 into 20, 40 liters. If you are more fatty, if you are more old, your body water will be less. So more fat, females, less water. So the calculation taken is 50%, 50 to 55% of the total body weight as water. So for normal purpose, we are taking 60% of the body weight as water. Whereas in a fatty elderly person, we take 55% of the body weight as water. So you give medicines, fluids, everything based on the ideal body weight and not on the actual body weight. The ideal body weight is calculated based on divine formula. What does the divine formula say? The divine formula says ideal body weight is equal to 50 kg for men plus 2.3 into height minus 60. For women, ideal body weight will be 45 kg plus 2.3 into height minus 60. To see an example, if a man is tall by 5 feet 5 inches, which converted in inches makes 65 inches, because we know that 1 foot is 12 inch. The ideal body weight will be 50 plus 2.3 into 65 minus 60, which gives 61.5. That is the ideal weight for a man. But of height 5 feet 5 inches. But the same 5 feet 5 inches lady will have an ideal body weight 45 plus 0.5 plus 2.3 into the same 5. So that is only 57 kg. So for administration of medicine and for administration of fluids, you have to take ideal body weight and not the actual body weight. Now we have also another weight that comes into play, that is called the adjusted body weight. So if a person is weighing 100 kg, you can't take 100 kg for the administration of fluids. So you have to adjust the body weight. How do you do that? Based on Divine's formula, we identify or calculate the ideal body weight. That plus 0.4 into actual body weight minus ideal body weight is the adjusted body weight. So if the above lady with obesity has a weight of 74 kg, her ideal body weight 57 kg, the adjusted body weight would be 57 plus 0.4 into 74 minus 57, which comes down to 57 plus 0.4 into 17, that is 63.8. So remember, her actual body weight is 100, but the adjusted body weight is only around 64 kg. So when you write medicines, when you write fluids, it should be based on the adjusted body weight and not on the actual body weight. But on the contrary, for underweight persons, the adjusted body weight is the ideal body weight. Don't go by the actual weight of the lean person. You have to take the ideal body weight and no correction is required. So to recapitulate what I said now, you have to find out the adjusted body weight based on the ideal body weight. The ideal body weight is given by the divine formula, which states that 2.3 into the height in inches minus patient 60. That will be the ideal body weight. For ladies, instead of 50, you take 45.5. 45.5 into 2.3 into height of the person minus 60. That is 5 feet. 60 is 5 feet. 65 is 5 feet 5 inches. So that is the importance these two sides. Now, let us see what is we said the body compartment has got major divided into ECF compartment and ICF compartment. The ECF compartment further has a plasma compartment. Plasma is again composed of 93% water and remaining is the solid non-aqueous phase. Then you have the interstitial fluid and all the transcellular fluid. ICF is constituted by, ICF has got only ICF, and the major cation in extracellular fluid is sodium, whereas the major cation in ICF is potassium. Similarly, is around 5 millimoles per liter in the ECF, whereas it is 0.001 only in the ICF. The abundant cation in the ICF is potassium and magnesium, in contrast to sodium and calcium in the ECF. Let us see what are the anions in the extracellular fluid and ICF. If you consider the anion, chloride is the major anion, followed by bicarbonate. In the ICF, we have phosphate of 107 and intracellular proteins. They are the major anions. This is very, very important when we consider electroneutrality and when administer fluids. So, what are the points to remember here? 40% of the body weight is in the intracellular compartment. The major cations are potassium and magnesium. The major anions are protein and organic phosphate, followed by ATP, ADP, and AMP. The pH of ICF is only less than the ECF, that is 6.8 to 7.4. These are the points to remember regarding the intracellular fluid. Now, what do you remember? What are the points to be remembered when you take the extracellular fluid? It is 20% of the body weight, not body water, 20% of the patient's body weight. The major cations are sodium and calcium. The major anions are chloride and bicarbonate. Chloride is abundant, 104, followed by bicarbonate, 24. And the pH is varying from 7.35 to 7.45. We take a neutral pH of 7.4. Now, why as nephrologists we are talking about fluids? Because kidney has got a very major role in maintenance of effective circulating volume. Kidney, by adjusting the sodium load, maintains osmolality. The other electrolytes also maintained within a normal, the biliary interior is maintained by the kidneys. If we may take more protein, more urea is generated, more urea is excreted. So the kidney has got normal kidneys has got an abundant capacity to alter the excretion based on the diet. Now, what is the normal water balance? What is the normal physiology? To put in a very, very simple terms, when we drink a lot of water, or first let us talk about water loss. If through heat stroke or something else or diarrhea, if you are losing a lot of water, the water content comes down, the osmolality will increase. But the physiology cannot allow the osmolality to go above a certain value. Usually it is maintained around 280 to 290. So it cannot go above 290. So what is the physiological mechanism. The physiological mechanism is increases thirst. So patient, if they are accessible to water, they take lot of water. The hypothalamus and the pituitary axis senses this, and ADH is secreted. So there is a decreased water excretion. So water is lost is gained by increased water intake and decreased water excretion. So the osmolality becomes normalized. This is possible only if the sensorium is intact, the patient thirst mechanism is intact, and patient has got access to water. Under normal circumstances, all these are intact, and so hypernatremia is prevented. On the other hand, if there is an excess water and there is a dilutional hyponatremia, there is a decreased osmolality. So if the osmolality is decreased, thirst is suppressed. So water intake is reduced. ADH secretion is decreased. So there is a aquaresis happening. So there is increased water excretion and the osmolality is normalized. So normally through thirst mechanism, ADH mechanism, the water balance maintains the osmolality between 280 and 290. Now, why are you fixing a volume as oliguria or polyuria, etc.? This is determined by the solute excretion, concentrating capacity of the kidney, normal diet, no loss, normal metabolism. So if the patient is taking on a normal diet, if there is no loss, is not febrile, the metabolism is normal, then the solute load generated by the body is 600 osmoles. The kidney can concentrate up to 1200 osmoles per liter. That is, 1 liter can contain 1200. But the normal physiology generates only 600, and to excrete the 600, we need only 500. That is, 600 by 1200 is 500. That is why any urine volume less than 500 ml in adults is termed or is considered as oliguria. Another point to remember is normal sodium indicates normal water balance, but volume status cannot be assessed from sodium. So, oliguria is defined as urine volume less than 500 ml. This is based on the osmotic load generated by the body. Normally, we are generating around 600. The kidney can concentrate up to 1200 1 liter. So to excrete 600, we need only 500 ml. Okay. Now let us see what is the normal intake of water and the water is generated by the body. So normal water intake, whatever we are talking now is for a normal person. It is usually 0.03 into weight in kg. That is, in a 70 kg adult, the water intake will be around 1200 ml. Water in fruits and vegetables, it is taken as 100% water by weight. Usually it is only 800 ml. The nutrient metabolism, oxidation of carbohydrates, etc., generate under 300 ml, constituting our total water intake that we drink and we generate to around 2400 ml. So what happens? We have to get rid of this 2400 ml to maintain a water balance. What do you mean by sensible loss? Sensible loss is what can be measured. What is perceived by us and that can be measured. That is the loss through the urine and feces. Usually 1500 ml in urine and 100 ml in feces. Insensible loss means what we cannot measure. It is not perceived by us. It is diffusion through the skin and evaporative loss from the respiratory tract. So through the skin, normally around 400 ml. Through the respiratory tract, around 400 ml. So the total loss is around 2400 ml. So if we take 2400 ml by our intake and endogenous metabolism, we are also losing the same amount through urine, feces, and insensible loss through the skin and the respiratory tract. That is why the water balance is maintained. When we write fluid, the point we have to remember is whenever a patient has got fever, there is an increased catabolism and increased metabolism. So the increased requirement of fluid is around 100 to 150 ml per day. That is 10% increase for each degree of body temperature elevation over 37 degrees. So if somebody has got 38 degrees, 150 ml per day has to be given in addition to the normal fluid. We will see that soon, quoting an example. There is a loss through sweating. In burns, there is an extensive loss through the skin surface. Tachypnea, hyperventilation, there is increased requirement of water. Surgical drains, polyuria, etc., etc. Gastrointestinal loss also contributes to increased water loss. So we have to increase the water intake. When do we reduce the water intake? Somebody has got oliguric kidney failure. When their air is, for ventilation purposes, you are using humidified air. If the patient has got volume overload as in edema, hypothyroidism, in syndrome of inappropriate ADH, we have to reduce the water intake. What is the indication for parenteral or enteral nutrition, which we are not touching today? This will be inadequate energy or fluid intake for more than 1 to 2 weeks. Then only we should think of parenteral nutrition. So let's see what is happening to this lady. This is the story of a 40-year-old man, weight 80 kg with fever, jaundice and oliguria. He is febrile, tachycardic, temperature is 100.4 degrees and tachypneic. Blood pressure is 70/50 and bowel sounds are absent. Labs show urea of 50 with a normal creatinine. Sodium is 135 and potassium is 4. What are the problems? This lady, this man, patient has got hypotension, patient has got tachycardia, fever, oliguria, and disproportionate elevation of urea. So what do we do next? So we have to write the fluid for this man. So we should write the resuscitation fluid. We should think about the regular maintenance fluid. We have to see whether the patient is losing. There's a continued loss of fluid. And if there is any deficit, we have to correct. How are we going to do that? So having found out what is the fluid to be given, we have to find out how am I going to give this fluid. Can it be given through the oral route? Is it to be given through the enteral route? Or it is the parenteral route? And we also should decide what type of fluid is to be given to this lady or man. So you always remember when I did my house agency long back, whenever some fluid is given, we had no idea of what type of fluid. Whatever fluid was available, we used to give. Maybe 5% exos, we may be normal saline. Half normal saline, 3% saline were never available. We had only normal saline and 5% exos and exosaline that time. So things are different now. So we should decide on the route of administration and also the type of fluid that's to be administered. So what are the resuscitation strategies? The first part of the fluid therapy, if somebody is in shock, we have to give as an emergency resuscitation fluid. The aim is to maintain the oxygen uptake and make the metabolism aerobic, to prevent anaerobic metabolism. If you have anaerobic metabolism, lactate will be generated and can produce metabolic acidosis. We have to also increase the cardiac output by achieving a mean arterial pressure. So what are the salient features you should consider when you write a resuscitation fluid? Colloids are superior to blood products and crystalloids to promote cardiac output. Packed cells should never be used. We know packed cells are only RBCs. It does not contain plasma. Crystalloids mainly fill the interstitial space. It does not go to the cell. From the vascular compartment, it immediately traverses and gets into the interstitial space. Only part of which stays in the vascular compartment. So you should give 3 times greater than colloids. When you give normal saline, it should be more than 3 times the volume of colloids. So your aim in resuscitation is to maintain adequate perfusion to all vital organs. So in an emergency situation, if the blood is not available and the patient is shock, you can use colloids. If you plan to use crystalloids like normal saline, plasmalite, etc., you have to give 3 times the volume of fluid that is lost. Never give packed cells. You should always remember only a portion of the crystalloid will stay in the intravascular space. Most of it will go into the interstitial space. So when you want to give a resuscitation fluid, first you give normal saline, plasma light or blood product, bring up the blood pressure. Then you have to assess the fluid status, whether the patient is hypovolemic, the patient is hypovolemic or euvolemic. This patient, if you go back, if you remember, has got a blood pressure of 75/50. The patient was tachycardic. The patient was oliguric. The blood urea was 50, thereby saying that the patient had hypovolemia. Now, how do you find what is the degree of fluid loss? This is essential to find out the deficit the patient has. Then only you can calculate the volume of fluid. The earliest evidence of hypovolemia we always reiterate or always emphasize is if the patient comes and says that they have lost around 300 ml of fluid or blood, and you check the blood pressure, it is 120/80. Don't be passive and think that the patient has an adequate volume. You have to check for a postural BP fall and increase in heart rate. That is postural BP fall, BP taken after 2 minutes, BP, systolic BP blood pressure fall of 20 and the diastolic fall of 10 makes it postural BP fall. This is suggestive of minimal fluid loss. In children, it is 5% of the body weight, whereas in adults, it is only 3% of the body weight. So if the assessed fluid loss only around 3%, if the replacement, the deficit fluid should be 30 ml per kg. So the mild hypovolemia can be picked up only by a postural hypotension and postural tachycardia. And in adults, it should be 3% of the body weight or 30 ml per kg. The patient is hypotensive, tachycardic, the mucosa is dry. That's not a reliable indicator because if you are doing dry tongue is not indicated because if you are mouth breathing, the tongue will be dry. You have to look at the longitudinal furrowing of the tongue and skin turgor elicited on the abdominal wall. This indicates a moderate degree of hypovolemia. In infants, this is 10%. We have to give fluid 100 ml per kg. In adults, it is 6%. We have to give 60 ml per kg. So usually the patients we get in the HDU or ICU are hypotensive, tachycardic, tachypneic, and the poor skin turgor, and urine output starting to drop. So usually they are of moderate hypovolemia. And if you give rush fluid, 60 ml per kg, usually you can bring them back to mild fluid loss and then to normal. But the patient has got an abnormal mental status, persistent hypotension, oliguria is established, and there are no bowel sounds as this patient. It is considered as a severe degree of hypovolemia. And in infants, it is 150 ml per kg, that is 15% of the body weight. And in adults, it is 9%, that the fluid requirement is 90 ml per kg. So whenever you see a patient with history of fluid loss, you have to assess whether the patient is having hypovolemia. If there is hypovolemia, what is the degree of hypovolemia? Is it only minimal, which can be picked up only by a postural tachycardia and postural hypotension? In adults is only 30 ml per kg. If the patient is hypotensive, tachycardic, and the skin turgor is diminished and the urine output starting to drop, then it is around 10% in infants, that is 100 ml per kg, and in adults around 60 ml per kg. The patient has worsened further, hypotension with ionotropes, abnormal mental status, no bowel sounds, urine output is around 100 ml, then the fluid requirement is assessed as severe. In infants, it is 15%. In adults, it is 9%. That is 90 ml per kg is the fluid that is to be given. So this patient who is oliguric, urea is high, hypotensive, tachycardic, has got a severe deficit of 9%. So the fluid required in this patient is 90 ml per kg. We saw that her ideal body weight is 60 kg and her actual body weight is 80 kg. So since he is obese, the adjusted body weight is taken. So that is calculated. If you remember the first few slides, it is ideal body weight plus 0.4 into actual body weight minus his ideal body weight. So that will get into a value of 68 kg. So we said earlier, when we write fluid, it should not be based on the actual body weight. It should be based on either on the ideal body weight in lean persons or in obese, it is on the adjusted body weight. So this man would require a fluid of 90 into 68, which gives a volume of around 6.1 liters. So for his deficit correction alone, we require around 6,120 ml, that is 6.12 liters. Now, how do you assess the fluid volume further? Earlier again, we used only blood pressure. We now know it's not a sensitive marker. It underestimates blood pressure because of flow through the partially constricted arteries. The gold standard in the ICUs are direct arterial blood pressure measurement is in hemodynamically unstable patients. And we should always remember, you are not going by the systolic blood pressure. You should go by the mean arterial pressure, which is given by the diastolic pressure plus 1/3 the pulse pressure. It should be maintained around 60 to 65. So the ideal way of looking at the volume or the blood pressure is by a direct arterial blood pressure measurement. And you should look at the mean arterial pressure, which should be maintained around 60 to 65 and not the systolic blood pressure. Earlier, we used to, whenever a patient comes, we always used to put a central venous pressure, and cardiologists also will measure the pulmonary capillary wedge pressure. Now it is not in fashion because of the so many complications. What are the complications? Because very difficult to put, it's an invasive access, catheterization is required, it varies with respiration, so may not be reliable. Now, the volume status can be assessed also by looking at the oxygen extraction ratio. How do you look at the oxygen extraction? If you have a central vein, you measure the oxygen from the central vein, peripheral vein, and also the oxygen by the oximetry. If the normal value should be 20 to 30%. If there is hypovolemia, it should be 30 to 50% extraction. And in hypovolemic shock, it is more than 50%. So if the patient has got a difference more than 50% between the pulse oximetry and central mixed venous oxygen, then it indicates severe hypovolemia and shock. CVP, and we earlier said they are not adequate because prediction of responsiveness to fluid is inadequate. Number of physiological variables affect these values. Complications are, you can produce a hemothorax or a pneumothorax, etc. And you require a catheterization expertise. How do you say patient is fluid overloaded? If the patient is dyspneic, patient has got raised jugular venous pressure, if the patient is edematous, if the patient has got bilateral basal crepitations, then we know this patient is not for hydration, this patient for fluid restriction. Now, there are so many other adjunct strategies for assessing volume status, not alone clinical. One is you give fluid responsiveness. You can give boluses of normal saline or plasmalite if you think the renal function is normal, and see whether what is the improvement in the mean arterial pressure and the urine output. You have to assess the cardiac output by an echocardiogram. You can also measure the tissue perfusion by looking at the lactate. Pulse contour analysis we usually don't do. Stroke volume variation can be picked up by the echo. The simple test we can do is a passive leg rising or a fluid bolus. The passive leg rising should produce more than 10% change in the cardiac index. So if you passively rise the leg and the cardiac index improves by 10%, that means this patient is hypovolemic. Now, what is the current state-of-the-art assessment for hypovolemia? That is focus, that is point of care ultrasonography. What do you do in this? You do measure the inferior vena cava. Where do you identify the vena in IVC? In its longitudinal axis, in the subcostal view, just behind the xiphoid. It is very, very important because we measure low. If the IVC is identified the lower place, it may give a wrong value. So you have to measure the IVC at the point where it has the right atrium. The diameter should be measured approximately 2 centimeters from the junction of the IVC and the right atrium. A change in IVC diameter with respiration of 12 to 18% is associated with fluid responsiveness. Now, every HDU or intensive care or critical care unit do measure intravenous IVC diameter and tell us whether the patient is hypovolemic or hypovolemic. All of us should get trained to measure, if you are interested in critical care and intensive care management, how to look at the IVC diameter. If you do an ultrasonography of the lungs, you can get the curly B lines. Now, what is IVC collapsibility index? That also tells you the responsiveness to fluid. That is IVC maximum diameter at expiration, but minimum diameter at inspiration divided by IVC max. That is IVC collapsibility index. So if you measure the calculate the collapsibility index, if it is more than 50%, it is hypovolemia. Don't think it is all of theoretical importance. Now, every intensivist or a person interested in critical care or a nephrologist, before giving fluids, look at the IVC collapsibility index. Now, this alone probably is not sufficient. You have to look at the portal vein, hepatic vein, or renal vein. Look at the congestion of these veins. If the veins are congested, that means the patient does not have hypovolemia. Currently, people started measuring thoracic electrical bioimpedance or bioreactance, but this is now still not practically used. Some centers do research, especially Dr. Priyamada from Pondicherry. She is very much interested in this bioimpedance. So she measures bioimpedance for every hypovolemia and tries to make it of practical importance. We have to do an aortic Doppler, and you have to also do a point of care echocardiography. All this is being practiced. So this is all of us should know about this. So now we have to treat the shock with bolus IV fluids, restore circulatory volume. How do you do? 10 to 20 ml per kg of sodium chloride as fast as possible and reassess if additional fluid is required. You should remember the fluid volume used for resuscitation is not used when you calculate the other fluids. What is the rate of volume of resuscitation? Rate of volume resuscitation, you should always remember that it is not the size of the vein, but the dimension of the venous catheter that makes the fluid fast or slow. So usually we use 8.5 French, 2.7 millimeter outer diameter, 5 to 6 inches in length. We should also go back from our original concept that Trendelenburg position will improve the blood flow. It is not useful. It does not increase the venous return to the heart. So there is no point elevating the foot end. So in this patient, with a mean arterial pressure of 56 millimeters, what is step 1? Emergency resuscitation strategy. Creatinine is normal, potassium is normal. So you can give 1 liter of ringer lactate. CVP goes to 12. Mean arterial pressure is less than 60 and his age is less than 45 and he has no cardiac disease. So you can give 1 more liter of ringer lactate and 1 unit of plasma and get the mean arterial pressure to 85. So what are the endpoints of fluid resuscitation? When should you decide you stop? Fast fluid should be stopped. Otherwise, you'll get into problem by producing pulmonary edema. So look at the CVP, look at the cardiac index, look at the oxygen uptake, look at the lactate level. So practical use is we no longer measure the CVP and PCWP. You can look at the cardiac index. You can look at the difference between the central venous oxygen and the arterial oximetry. You can measure the lactate and the base deficit. If these values are achieved, you can think your resuscitation is complete. So having completed the resuscitation, you have to write the routine maintenance fluid. So how do you do that? Aim is to, all of us, whether we are sick or normal. If we are normal also, we take certain amount of fluid. We also take certain amount of electrolytes, knowingly or unknowingly, and also calories. So our normal requirement is 40 ml per kg in men and 37 ml per kg in women. This is the volume of fluid for maintenance. 40 ml per kg in men and 37 ml per kg in women. So in adults, usually it is 30 to 40 ml per kg. So in this patient, maintenance fluid requirement will be 16 to 40, that is 2400 ml. I have taken the ideal body weight, not adjusted body weight, for ease of calculation. So 16 to 40 is 2400 ml. We should remember this patient was running a temperature of 101.4, 100.4. So every degree rise of temperature, we said there is a 10% increase in requirement. So in the 60 kg adult, with temperature of 100.4, the fluid requirement will be 60 into 40 is your maintenance fluid, that is 2400, plus 2 into 10% of your maintenance requirement, that is 2 into 240 will be 480. So you should also give fluid for correction for fever. So this patient should receive a total maintenance fluid of 2480. So we said there is a deficit of around 6 liters. The maintenance fluid requirement is around 2.5 liters. And how do you, in children, how do you do? And in adults, how do you do? 4 ml per kg per hour, this is for children, for the first 10 kg. 2 ml per kg per hour for the second 10 kg. And 1 ml per kg for the remaining. So 60 kg adult, it will be 40 plus 20 plus 40, that is 100 ml per hour. In 24 hours, they should receive around 2400 ml. Now, when we write the maintenance fluid, it should be something which is similar to the body compartment distribution. We said earlier that the body compartment, that is why the initial slide I showed the distribution of body water. 2/3 is in the ICF and 1/3 in the ECF. So when you give a maintenance fluid, it should be such that 2/3 should go into the ICF and 1/3 should go into the ICF. That is how you prescribe a maintenance fluid. So it can be given 2/3 as 5% dextrose and 1/3 as half normal saline. For maintaining, giving crystalloids, we can give 1 liter of half normal saline, to which we are adding 20 ml of potassium to correct the hypokalemia. The remaining requirement can be given as 5% dextrose. So this is how you maintenance fluid is returned. This patient requires around 2.2 liters. Liter can be given as 2/3. You should give as 5% dextrose and half normal saline. The remaining you should give as half normal with potassium. If there is any remaining requirement, that is given as 5% dextrose. Adequacy is judged by serum sodium, which should stay within normal. 130 to 150 is a very wide range. We would like to keep it between 135 and 145. And if possible, bed weighing machines are available, you can weigh and decide. Now, having said all this, you should instruct the sister how much and how do you give. So how do you find out the number of drops per minute to be given? So if somebody has to receive 4 liters, 4 into 11, that is volume of liters to be infused in 24 hours, into 11, that is 4 liters to be given, 4 into 11, that is 44 per minute, is the drops that is to be given. If you want to give use a micro infusion, it is the number of drops is per minute is equal to number of ml per hour. That is, if you want to give 10 ml per hour, you set the infusion to 10 microdrops per minute. So to reiterate, if somebody has to receive 3 liters a day, then the fluid you have to give at the rate of 33 drops per minute in a macro normal infusion set. If you are using noradrenaline or adrenaline, and if you are aiming at 15 ml per hour, then you have to give micro infusion set and you have to set it to 15 micro drops per minute. So this is also to be told to the staff if they are not aware of this. So we said, already discussed this, with maintenance requirement for electrolyte water, this is, we have already discussed. Now, maintenance fluid, what are the questions to be answered? How do you want to give? Route of administration, oral, Rayleigh tube, most physiological, because we can replace proteins adequately. Micronutrients can be given. You know, kanji water is very rich in magnesium and phosphate, which are essential for prevention and boosting your infection and boosting your immunity. Usually, it does not produce a fluid overload, and the danger of infection is not there. So whenever a patient can be started on oral or Rayleigh tube or enteral fluids, you have to switch from parenteral to oral tube. If a patient can already take oral, don't give parenteral, start them only on oral. So if you want to give oral, we should have an idea of what is the electrolyte content. If you take 1 gram of sodium chloride, that is our upper, that contains 17 milliequivalents of sodium. If you take 1 gram of sodium bicarbonate, it contains 12 milliequivalents of sodium bicarbonate. Similarly, 1 gram of potassium chloride is available as Sindupur, it contains 13. And calcium carbonate contains 20 milliequivalent per gram. So this is if you want to give oral fluids. If you want to prepare some fluid based on the requirement, you should have an idea of this. Sodium chloride, 1 gram is 17. Sodium bicarbonate, 1 gram is 12. Potassium chloride, 1 gram is 13. And calcium chloride, 1 gram is 20. So rate of administration of electrolytes and glucose, usually sodium can be given 100 milliequivalents per hour. This is a maximum rate, 100 milliequivalents per hour. Potassium, 20 milliequivalents per hour. We never go to 20 milliequivalents per hour. I have not used, to be very frank, not more than 4 milliequivalents per hour, because I am very much scared of this hyperkalemia and cardiac arrest. Calcium, 20 milliequivalents per hour. Magnesium, again, 20 milliequivalents per hour. Bicarbonate, 100 milliequivalents per hour. And glucose is 0.5 gram per kg per hour. This is the maximum permissible rate. That does not mean that whenever you write, you should write like this. If your patient is in a very critical state, and if you want to give electrolytes, and patient is severely hypokalemic with 1.5 potassium, then you can go up to this rate. But normally, we don't exceed more than 6 milliequivalents per hour. And sodium also we calculate and write. So this is the maximum permissible rate. Now we said we have finished resuscitation, routine maintenance. Then we said replacement of the ongoing loss. Saliva, maybe during Ramadan season, people will be losing a lot of saliva because they don't even swallow saliva. So that is usually the content is shown. This is not to be learned by heart. This is what you should know, because when somebody has got a pyloric stenosis and vomiting, then the fluid loss contains sodium, potassium, and chloride predominantly. If somebody has got a pancreatic lesion and not fluid is sequestrated, the fluid loss is sodium, potassium, and bicarbonate. Diarrhea also contains a lot of sodium, potassium, and bicarbonate. Colon contains some amount of chloride also. This chart, it is better, surgeons especially, because we have a continuous right tube aspiration after gastric surgery. You have to measure the gastric juice. If the 1 liter is lost, then you have to give 1 liter of normal saline with potassium added, because that will be corresponding to the gastric juice. That is the importance of this slide. So if somebody has got a duodenal drain or a jejunal drain or a colostomy, whatever fluid is lost, you have to measure, and that should be given in this composition. So that will be physiological, that will correct the electrolytes. So in this man, total fluid requirement will be deficit plus maintenance plus replace ongoing loss. The most accurate way to correct or calculate child's fluid deficit is by measuring the weight. Now, what are the common fluids used for parenteral administration? We have normal saline, which contains 154 of sodium, 154 of chloride, no potassium, no calcium, no glucose. This is not very physiological because our serum contains only, plasma contains only 104 milliequivalents of chloride, whereas normal saline contains 154 milliequivalents. So you are giving more of chloride, and that can produce chloride acidosis. If you look at the half normal saline, It's just half of normal saline. 77 milliequivalents of sodium, 77 milliequivalents of chloride, and nothing else. In dextrosaline, it also contains sodium and chloride like normal saline. The only difference is 5% dextrose will contain 50 grams of glucose per liter. That is 100 ml is 5 gram. So 1000 ml will be 50 gram. 5% dextrose has no electrolytes. It contains only 50 grams of glucose, which gets metabolized as soon as enter the circulation. So it is equivalent to giving free water through the Rice tube. So if you give 1 liter of 5% dextrose, it is the same as drinking 1 liter of water. Ringer lactate is the most physiological fluid. It contains 130 of sodium, 4 potassium, 3 calcium, and 109 chloride, and bicarbonate will be 28. We don't use ringer lactate as the first line because we are not sure of the renal function. If somebody is brought to the casualty in a shock state, they say that patient has not passed urine, you don't have the electrolytes, to give ringer lactate will be suicidal. That is why you usually give normal saline as the first resuscitation fluid. There is blood loss, you give blood. Now the balanced solutions are available, which we have is plasmalide, which is identical to plasma. That is sodium is 140, potassium is 5, magnesium is 1.5, chloride is 98, acetate which gets converted into bicarbonate is 27. So it is almost identical to plasma. That is why it is called as a plasmalide, and the osmolarity is 285. Only problem is very expensive. So to use for a routine, and many studies have shown that balanced salt solutions have no superiority over conventional crystalloids, considering the expense involved. So most of the centers still prefer using crystalloids. So what are the colloids available? Now, earlier we used to have FMAS, hetastats, etc. Now, the common colloid we use is the 5% albumin, which contains 160 sodium, 136 chloride, and also around 50 grams of albumin. So 5% albumin is the colloid which we use normally. Himaxil is also available, but is usually not used. Now, let us see how these fluids get distributed. So you remember the basic diagram. If you give a fluid which is going to stay only in the intravascular compartment, that is blood, you know, the interstitial space usually does not contain blood. It does not usually contain plasma. So if you give 1 liter of plasma or 1 liter of albumin, it is going to stay only in the vascular compartment. It will not replenish the interstitial compartment or the intracellular compartment. And also the point you have to remember is, as a first physiological compensation, whenever there is a blood loss from the vessel, the interstitium gives fluid to the vascular compartment, and the interstitium also suffers. So whenever you correct hypovolemia and shock, if you give the intravascular fluid blood, you have to follow it up with another fluid that is going to enter the interstitium also. So this is the distribution of normal saline and ringer lactate. We said that sodium is not entering the cell. So whatever fluid we are giving is going to stay only in the extracellular compartment. That is, if you give 1 liter of normal saline, 3/4 will go to the interstitium, and only 1/4 will stay in the vascular compartment. That is why we said, if you want to give, if somebody has lost 750 ml of blood, it is not enough you give 750 ml of saline, because only 250 ml will go to the vascular compartment. You have to give 3 times the volume of blood that is lost if you are planning to give a saline. It does not replenish the intracellular compartment. So we said when the intravascular compartment suffers, the interstitium gives fluid to the intravascular compartment. If that stage also we are not able to correct, then the cellular dehydration occurs. So we have to use a fluid which is going to enter the cell also. So one fluid that can enter the cell is half normal saline. It behaves like 500 ml free water and 500 ml of saline. So if you give 1 liter, 332 will enter the cell, only 167 will be in the vascular compartment, around 500 will be in the interstitial compartment. So half normal saline will be an ideal fluid if you want to replenish the intravascular compartment, interstitium, and the intercellular fluid. If you consider 5% dextrose, if somebody has got hypovolemia, hypotension, and if you start giving 5% dextrose, see what happens. If you give 1 liter of 5% dextrose, only 52 ml will stay in the vascular compartment. And only 208 will go to the interstitium. The rest of it is going to enter the cell. So the extracellular sodium will get diluted by this volume, which is free water, and the hyponatremia will get aggravated. So again, 5% dextrose is a maintenance fluid which can be given to replace the intracellular dehydration. Half normal saline is the ideal fluid to replenish intracellular compartment, interstitium to a certain extent intravascular, and ideal first fluid to correct shock, hemorrhagic shock will be blood or blood products, but should be always followed by a fluid that enters the interstitium, that is the Ringer lactate, if the potassium is normal or normal saline. So this patient has got an SS deficit of 9%. Fluid required is 90 ml per kg. So the volume comes to 5,400 ml. We should always remember that total correction is not required. Only 50% of the deficit is to be corrected. So 5,400, 50% is 2,700. The maintenance fluid is based on adjusted body weight. So 30 ml per kg, adjusted body weight was 68. So 2040 ml. There is no ongoing loss. So the fluid that this man has to receive is 2,700 plus 2,040. That gives to 4,740 ml. So to summarize, we have the last 45 minutes or so, I had been trying to tell you what is the distribution of body fluid in various compartments, what is the relevance of this when you prescribe IV fluids, how do you assess hypovolemia, oral Rayleigh tube or enterostomy is the best physiological route, parenteral nutrition should be considered only after 1 to 2 weeks, and you should always remember that you should not overload the circulation as well. So whenever you aggressively give resuscitation fluid, you should monitor for oxygen extraction ratio, the cardiac index, and the mean arterial pressure, and you should not overshoot. You can also measure the lactate, which is easily available. The blood gas machine gives the base deficit, which should be maintained around ±3 to +3. Thank you very much for your patient listening.